Dr. Graham directs the Center on Social Determinants, Risk Behaviors, and Prevention Science at RTI International. He's a National Prevention Science Coalition board member, and he has more than 25 years of experience conducting community-based research and evaluation. His research focuses on evaluating preventive interventions developed to reduce and prevent adolescent interpersonal violence and substance use. He currently serves as the Principal Investigator for NIDA's HEAL Prevention Initiative, Coordinating Center, which collaborates with 10 research sites awarded to develop interventions to reduce opioid misuse among older adolescents and young adults aged 16 to 30.
Good afternoon. Clearly I offended everyone. Good afternoon.
Hello.
On behalf of RTI and NPSC, I want to welcome you to coming out this afternoon. We've heard why it's so important not to equate opioid dependence and addiction. And much of what you've heard today has rightfully focused on treatments and the role of stemming this tide. But I also want to take a step back and really talk about the role of prevention. More specifically, today my remarks will focus on, one, the importance of making prevention an important piece of the general conversation, that we understand that it has a significant role in this effort. But also as an equal partner to efforts to address the epidemic, not only today, but for future epidemics. And today's presentation will be compartmentalized into 4 sections. First, I will provide some historical context of the epidemic and prevention science's contributions and challenges. Then second, a cautionary tale about the need to what I call keep an eye on all balls and not just the shiny one. The third part will really focus on the promise of our current efforts. And finally, I talk about what the future might and should hold. Now, to do this, I want to anchor it in time, and that year is 1991, and for 2 important reasons. It was a year unbeknownst to me at the time that I became a prevention scientist, and probably most important is the year I got married.
There you go.
So, in 1991, there were about 13,000 deaths from drug poisonings, and that's about 5 per 100,000. But if we fast forward to 2017, that went from 5 per 100,000 to 23 per 100,000. And of those deaths, 22 of them are related to drug poisonings. And so that kind of puts in context where we've come from 1991, when I got involved in substance abuse prevention, research and evaluation, to where we are now. And it puts in context the importance of this epidemic. And during that time, and over the last 30 years, prevention science has had an important role. We have developed lots of interventions designed specifically to understand substance use. But there have been 2 problems along that time. None of those strategies that have been implemented over that time frame included opioids in terms of really understanding to what degree and extent do those intervention strategies really prevent opioid misuse and abuse. Secondly, we don't know much about the pathway to addiction. And I think you've heard that a couple times today. And one would say that can't be true. And part of that is how we talk about stigma and how epidemics kind of take over the media. And so instead of understanding under what conditions is one more vulnerable for addiction, we've had to focus on the problem at hand. Thousands of individuals die every day from this epidemic. And so while we need to understand the underlying causes, in the midst of any epidemic, there's a need to focus on it. And so as we think about it from a prevention science perspective, we have to understand, do that current set of interventions also reduce opioid use and escalation to disorders? And what are those key pathways? So that as we look at intervention development, we can put them in their proper space. And I just want to put this in context. So, in looking at Google Scholar, one of the things, how many studies are there that use the word opioid prevention? And now remember, when we say opioid prevention these days, we're also talking about preventing overdose and deaths. And what I really want to talk about is how we prevent misuse. There are about 213 articles, but if you do opioid treatment, that goes up to 23,000. And as I said before, that does not in any way negate the importance of really focusing on treatment and reducing deaths and overdose, but it puts in context of where our focus is. And I don't expect that to be 213 to 213,000 on both sides, but what it also speaks to is we are not investigating, we are not writing, we are not disseminating the work as it relates to opioid prevention. And so this is, again, just to quantify and to put it in context. The other part is we're in an unprecedented time in terms of resources. And some might say not enough, but those of you who've been doing this work, you know these dollars had never been seen before. Just in FY 2018, about $7 billion spent on this epidemic. Most of that in SAMHSA, but you'll see 11 other agencies. And for those who follow funding, almost every federal agency now has an opioid piece woven into the work they do in some place. But what I contend is that when you look at where we are, that trend in terms of deaths is still going up. And part of my presentation today and part of my plea to the representative staffers in the room is unless we understand the value and importance of prevention, we can never ever bend that curve. We can't treat ourselves out of this epidemic. And so understanding a more holistic approach to this work is critical as we move forward. As prevention scientists, it's also important for us to think about addiction and dependence in the broadest sense possible. We need to understand our present dangers, but also important, we need to make sure we are not ignoring related dangers. As such, you've seen this slide already, and so this is how presentations come together even when folks aren't coordinating. So I like that. And this talks about those three waves. Brendan already stole some of my thunder and mentioned waves 4 and 5, so I'm actually going to do a better, prettier slides. How about that? But I want to talk about, in addition to these 3 waves, an additional set of waves what I think we must not ignore. And it's what I think about is what I call wave 4 and 5, but more importantly, it's the what and the who. The fourth wave really, the fourth wave, we really need to be aware of what is that next drug of choice. Drug-related epidemics are not a new phenomenon. The thing that's different here is we have a deadlier killer. It is more potent, but it's opioids today, it was something before that, and it'll be something tomorrow. So understanding as we develop interventions and think about substance use, that we don't forget all the related issues that are attached. And for example, when you look at the rise in overdose deaths in America, this is an example of what the what is. And so here you see almost a 53% increase in cocaine-involved death rates, as well as psychostimulants. And so, again, thinking about not only opioids, but substance use in general. And that really goes to understanding the underlying causes. As I often tell folks, if you look at substance use in rural communities, it is often higher than others. So it shouldn't be a surprise that opioid deaths are higher in rural communities. Again, many of the same underlying factors that led to addiction and dependence in general didn't go away, but just again replaced with a different substance. So everything that we do doesn't have to start from scratch, but making sure we are connecting the dots in a way that really understands those relationships. That fifth wave really is about the who, and again, Brendan really began to put that in context. I want to show the data that goes along with it. When we look at the increase in deaths have increased in all demographics. As we know, still males dominate that, and so they have increased, they have the highest death rate. But when you look at the largest relative increase in terms of deaths from synthetic opioids, those are African Americans at 60% and Native Americans. And again, these data are not new. That's a change from 2016 to 2017. We're currently in 2019. And so, as I said before, making sure we are looking at this epidemic and this phenomena in its complete scale is critical as we figure out what are the best ways to intervene to really tackle this epidemic. So the question is, what does the future hold? And how do we support the role of prevention to address both the current epidemic and future epidemics? We mentioned before about the importance of telling stories. And one of the things that I've talked about is, what does an empirical story look like? How do we take the data that we've collected, attach that to real people and real individuals, and put it in context? And from a prevention standpoint, we have an incredible challenge. The job of me, Denny, John, and others in NPSC is really to prove a negative. When prevention has done its job, you don't see anything. And so it's much easier to talk about the number of people who receive treatment, the number of deaths we prevented, but how do we talk about the number of people we prevented from ever getting to that point? That is both our cross to bear, our challenge as prevention scientists, but really about how we tell stories. How we tell stories that are empirical in nature, that makes the case for how prevention is a part of the solution, not an afterthought, but a forethought. So part of that starts with funding. And so first we need to conduct more research on the opioid prevention space, and this includes funding to test existing interventions and make sure they may have an impact on opioids, but also how do we begin to fund and test new strategies that are being developed. And so here's the great thing, in having Dr. Volkoff in the room, I get to give her a personal shout out for NIDA and NIH's work in this space. And so one of the efforts that's just come in is called the HEAL Prevention Initiative. There's a larger healing initiative that's about tackling opioids at multiple levels. But this particularly looks at first step in what I call the right direction. 10 research projects have been funded across the country to really establish evidence-based interventions, and they're really that prevent both the initiation of opioid misuse, but also the escalation to OUD. In addition to that, what we hope is by sharing and testing new interventions that we can begin to do a better job of scaling up and disseminate to a larger community. The other aspect of this understanding, looking at this epidemic in multiple settings. This particular project, these 10 sites, we've categorized them into 3 categories. One, indigenous and vulnerable populations, and understanding, again, as I mentioned before, Native Americans are one of the highest increased populations, but also healthcare settings. What does it look like to deliver interventions in that space? And then understanding systems, and that's both criminal justice systems among young people as well as human services. So we are in the beginning stages of a unique opportunity to really test and understand that. But this leads to 2 important questions, and also hopefully provides me an opportunity to be a little provocative. That first is, and what might this look like in practice if we're really taking this to the next level and understanding prevention's role and value? And the second is, how do we leverage the potential of settlements in this space for manufacturers and distributors? A new funding source that may not be constrained and constricted by deliverable dates, funding sources, and continuing resolutions. And so one of the things that I've learned in talking to states, what often happens is, and to give you a classic example of this, what's called the State Opioid Response Act. And so most of those dollars go to behavioral health agencies and focused on treatment. 60 to 90 days before the funds have to go back, unspent funds have to go back to Washington, there's this run to find prevention providers and say, we have this extra money, what can you do with it? The answer should be nothing. What often happens is prevention is a last resort with an understanding that nothing can change in 30 to 60 days. These issues of despair that lead to addiction and dependence didn't happen overnight, and they won't go overnight. And so one of the things we really need to advocate for is that there needs to be equal funding, or at least a better proportion than what we see now. How about, for example, we think about using these funds, these settlements, in a very different way. They're not constrained by the timelines of having to have something done in a normal funding cycle. And so one of the things that we've been talking about is returning to something that was around for a while. And so the question is, what would a prevention-prepared community look like? And so for me, this notion of a collaborative effort across multiple sectors, and that would include human services, education, justice, mental health, and even legislative branches of the government. But it's based on the following premise. How can we tear down silos and barriers and understand a single intervention with a single population is not going to tackle an epidemic? And so what we're asking in the context of prevention is really think about how agencies can target common risk factors, collaborate and provide technical assistance at a community level, not an individual level. And most important, how can we coordinate those efforts in a way that communities understand their voice, their value, and their contribution to the efforts. So in closing, I want to put this in context. We are just beginning on this journey of trying to figure out how we think about this work more comprehensively. And so what I ask is that we move away from silos and understanding the promise of what an integrated approach to the opioid epidemic and whatever the next substance use disorder epidemic is to come, that understands the value of prevention, harm reduction, and treatment in a coordinated and not isolated way. So with that, I say thank you again for the opportunity, and we look forward to working with you in the future. Take care.